Okay, thank you very much for joining us. Don't worry if you haven't had a chance to look at the videos. Don't worry if you don't know a huge amount about EPAs and learning records and how these are going to be used. This is an open question and answer session, and there's no question which is in any way a silly question. There's no question which is a silly question, and any question that you ask, other trainees are going to want to know as well. So we're going to start by asking, first of all, does anybody have anything they'd like to clarify in terms of the introduction of entrustable professional activities as a learning tool for GP training? Okay, so let's open that a little bit more. Does anybody feel it's a good idea or not such a good idea to go down this route?
You can be honest.
No, go ahead, Peter.
Yeah, no, I think it's a good idea just to honor different, like, I guess, presentations that we're going to be dealing with, and a good way to kind of follow up of how we're getting on over the 4 years.
Okay, so far what I'm hearing is that you like what you see.
Yeah.
Right, and then that means that you've looked at the software. Easy to work out what to do with it.
Yeah, pretty much. I suppose I had one question. I was just looking at, with the pregnancy EPA number 14. Just to clarify, I think there's obviously the case-based discussion and the PIP-C and PIP-P.
Yes.
Am I right in saying that you don't need a supervisor for this case-based discussion? You kind of just talk through a presentation.
Well, actually, to do any entry, you do need another person.
Okay.
Yeah, because you need to talk with them. You need to get some feedback. This is all about supporting learning conversations. So you need somebody to give you some idea of what did you do well in this case, and what could you have done better, or what might make the next time you do this work better for you. However, you have complete freedom as to who that person can be. It could be the staff nurse. It could be the registrar, it could be, but it should be somebody who you could argue knows a bit more about it than you. We are thinking about bringing in peer reviews without supervision levels, because it would be silly to have a supervision level, to be giving a supervision level to your peers. But if you're in a team and there's an SHO on that team who has three years experience in obs and gynae, for example, it would be perfectly reasonable to say, can you tell me what I would do next time that I might do it a bit differently, and put in their email address and put that in as an entry.
Yeah, perfect. Thanks.
It's a shame, Peter, you answered first, because I can't pick on you now as a Limerick, cold Limerick person. You were going to be my go-to peer pressure to get involved.
I had to get in there first, So.
Yeah, that's it. Yeah, it's like you managed the situation very well there.
I also see Hassan, who's from Ballinasloe. Hassan, thank you very much for joining us. You're very, very welcome. And Aislinn, who's in one of the Dublin schemes. Aislinn, do you want to put on your camera there and unmute? This is a small enough gathering that you can stay unmuted.
Yeah. Maybe.
Now, go ahead, Brian.
Well, maybe we might go around the table and maybe people could just give us their thoughts on it so far from what they've gathered, or if they haven't gathered anything, that's fine. We can fill in the gaps in the information. So I'm going to start picking on people, if that's okay, because Zoom has this lovely habit of actually ordering people. So at the top of my screen is, apart from Peter, is Alison. So maybe Alison, do you want to give a bit of perspective? And there's no wrong answers here, and there's no, like, we're not here to catch you out or to test you or anything. It's just literally to see where you're at and to support you in the next step.
Sure. So I suppose I don't personally have much experience with EPA. I haven't done my kind of women's health rotation yet. I do understand it's the first EPA you've introduced out of, I think, 18. And I understand it's an electronic record of learning. I think it's good to have kind of a dedicated, location to have all that information, and kind of an incentive to actively log and kind of reflect on your learning in kind of areas areas of development, it's certainly like an incentive to ask for feedback and to kind of identify what you need to work on. So I think it'll be interesting to introduce, and I'm looking forward to trying it.
Can I pick up on just for everybody's knowledge too, just to clarify around what the women's health requirement is. So this is this document I'm sharing here is publicly available, or it's the CST requirements. So what we've done with it at the moment is that we've replaced the women's health requirement, which is known here as women's health law, with this EPA structure. So the actual 18 EPAs, well, some of them to greater degrees and some of them to lesser degrees, can be used for this requirement. So the 18 EPAs could in time replace a lot more, things like hospital logbooks and things like that up there. But at the moment, just to make it clear in your minds, these are the 10 things along with your summative modules that you have to complete. These are the 10 things you have to do in GP training. So what we're replacing at the moment is this, but it could be used in several EPAs, is what I'm getting at, kind of way. But thanks for that, Alison, that was great. I might just keep going around, and what we might do is kind of a delta thing, if that's okay with you, Karina, because just to get people's perspective on what they know so far. So if it's something we've covered already, or it's been answered in an earlier person has touched on it, we can omit it, or if you're not clear yourself, we can revisit it. But to probably focus on what's new to you. So, and Mira, you're next to my screen because Peter excused himself, as I say earlier.
So I'm not quite too familiar with EPA. I know it does replace a logbook, but I'm not really sure what it involves so far. So I think that's
okay. I'm going to tell you what. I'm going to make a note of that, because I might do a demo for you later on, Karina. I think that'd be good, wouldn't it, to show.
Just before you do the demo, we've put up 5 training videos onto the website, which is called ICG. I see heads nodding, so people know that they are there. It's very difficult to find time for these things, but each of these videos is only 10 minutes long. So we hope that you can get little periods of time here and there. And you don't have to watch them in any specific order, but obviously the introduction to EPAs and the overview of women's health would be 2 early ones that you should view. It may be that nobody has had a chance to see them who's here present yet. Has anybody had a chance to see them? Would anybody like to make a comment on any of them? Okay, Brian.
Yeah, okay, Karina, sorry, yeah.
No, you go ahead on talking.
One thing Alison mentioned, but I forgot to go back to. So you mentioned you're not doing your obs-gynae rotation yet. What are you doing at the moment, rotation-wise?
So I'm in the emergency department.
Perfect. I hope you said that. So my point of that was that you don't have to wait until your obs-gynae rotation to do your women's health requirement, because the idea behind it is really that you're doing it the whole time. And this is the whole idea behind this whole new system. And instead of being this, a kind of tick box exercise, that it's much richer, earlier feedback. So if you see an interesting case coming in, let's say query a topic, pull out the app, drag the reg to one side and say, how do you think I manage that? And then just bang it into the app. And that's it, done. 3 minutes, done. And you might see that topic when you're in 3rd or 4th year, and you can say, well, I remember that case at that time, that reg said to go to that guideline. And you'll be able to, in our system, go back and say, that's the guideline. Oh yeah, there you go. You're that kind of way, so it'll become very rich. And if you're spending more than 3 minutes on it, you're putting too much work on yourself. Just literally pull them aside and say, like, this is what I'm putting in. Are you happy enough with it? Grand, bang on. I'm just going to keep going around. So, Jack, did you want to come in next, because you're next on my hit list? Your microphone might be going to a different microphone. You're unmuted now, but
Hello? Go ahead.
No, I don't know a huge amount about the EPA either. I think it's definitely a good idea to be moving towards this from just the paper logbooks, but no, I haven't used them before.
Yeah, I think there's also an important point to make, which is we're hoping to actually move ahead and start replacing all the other rotations. So even though at the moment you are the first cohort of trainees for whom there's only one element which is mandatory to use these learning records, it could well be that by the time you're in 3rd year in your training practices, that this will have come in so much that you'll be using them for your GP training practices as well. So there's no harm in getting ahead. The more entries that you have, the more that you have to demonstrate your learning. The other very important point is we expect you to show that you need high levels of supervision when you start and when you start in any rotation. And one of the things that progress mentor and perhaps with higher level review committees will be that you can show that you've a learning trajectory. So getting in a few entries there at the beginning, just showing that you do need high levels of supervision is probably a very good thing.
So did you have any other comments, Jack, did you want to make, or?
Not really, no.
Okay. I'd really encourage you all just to pull out the app and get on board. I mean, people have been emailing me at curriculum@icgp, and that's the place to come, and I'll follow up with you there in terms of resetting your passwords. I sent them out during induction, but I think everybody missed them, which is understandable. So we can just reset them now if you get them on board. And it's probably worth doing that now today and just having that in your back pocket. So as I was saying to you to Alison about dragging the reg to one corner. So if you see an interesting case, just say, right, that was interesting, or, even if it was an interesting case, maybe it's a routine, commonly seen thing, that is also equally valid. Is it Quaylon, is it? Next?
Elon, yeah.
Elon, sorry.
Yeah, so I watch those videos and everything, and it sounds very good. I've downloaded the app and have the logins and everything, but it just doesn't, I can't seem to record anything.
All right, you're having tech issues, yeah.
Yeah.
Is it that it's blank, is it?
Yeah, there's nothing when on the video online. If you scroll down, all the different EPAs are on the left. Nothing comes up on mine at all.
Okay, send me an email at curriculum@icgp and I'll follow up with you one-to-one on that and we'll get you sorted. Sometimes the first sync can be quite laborious. You have to sync it on Wi-Fi, have your phone plugged in and keep the app as the active app, and then it'll get through it eventually. Now they are bringing a new app out in the next few weeks or months, well, next month or two, which they promised me will address that. I mean, I'll be honest, we are pushing at our side to give you the best tech experience we can. But if anybody's ever worked in tech development, yeah, so you have, there you go, you're laughing. So, so whilst Google has probably $1 billion or whatever euro a year to develop tech, we don't quite know. We are giving this good resources, but in terms of supporting you, we're always available. The tech solutions we're always working on. So we apologize in advance for tech issues, but let us know. We'll compile a list. Okay, Aisling, did you want to come in there? You're muted, Aisling. I like your sunroof. I'm jealous. You're still muted, I think. You might have gone to the car with Bluetooth. Sometimes that happens when you're in the car if you Bluetooth for the car. Tell you what, I'll come back to you, Aisling, if you want to try and figure out when you're ready. Aisling, just come in top of us there. Maybe Amy, you're next to my my screen, so maybe if you want to come in terms of what you know so far in terms of EPAs or any questions around it or tech considerations or support.
Hi, yeah. So I watch the videos and have the app, but like Keelan, it's just blank. It won't sync for me.
Okay.
But yeah, I've watched them, so hopefully I can start recording stuff.
I tell you what, drop me a line at curriculum@icgp too, and I'll combine it into one ticket, and that way then I'll be able to reply to you both directly for a solution on it.
Thanks.
In terms of the non-tech issues with it, any questions around it or?
No, I suppose my obs gynae rotation is not till the end of the year, but I'm an ED now, so I guess I can start recording stuff once I get it running. Yeah.
See, if you think about it, classically the logbooks rotated in relation to the rotation you were doing, but the way we're going to go forward, they might not be. So I think be pragmatic. And see, the thing is, if you come into third year in training and you say, oh, this is my learning record to date, your well, it's going to be, I guess, your competency committee or your trainer in third year is going to be able to say, oh, great, that's what you've done so far. This is what we can do now. Do you know that kind of way? So it's building it up. So 2 more to go, and then when I come back for bits and pieces. Hassan, you're next to my screen. Hassan's got an even bigger sunroof.
Yeah. I have an ops and gynae rotation in Portinkla Hospital at the moment. Yeah. So I have watched the videos and I have the login details at the moment, but I haven't made any entry yet. I think it's a good idea and stuff. Just one question: can my registrar approve that the case discussions and how I am examining the patient? And can I ask my registrar to watch this and sign it off myself?
Not only can it be your registrar, it could be the CNM in colposcopy, it could be the ward sister, it could be the hospital pharmacist, it could be an SHO in obs and gynae who's got 2 or 3 more years experience than you. You are free to choose whoever it is that you want to be the person that you bounce your learning conversation with. The only thing is, it probably shouldn't be an absolute peer. We are thinking of bringing in peer records, but if we do bring in peer so that you can have learning conversations with your peers, but if we do that, we probably will take out the supervision level because it's not fair to ask for a supervision level from a peer. But we're trying to make this as flexible as possible. We're trying to make the data entry as quick as possible. We're trying to make this serve your learning needs. We're trying to make this useful to you. We don't want this software to be something that becomes a drag or a nuisance or a chore for you. One of the great things about it is, for the first time at every point with every single case, you have guidance at your fingertips as to what is expected of an independent GP. And you can choose lots of different areas to explore, and you have good guidance about what is expected of you, and seek feedback about how to get to that level. And we think that the clear expectations, we believe, will really help your training.
Yeah,
just in relation to your question, Hassan, in terms of specifics, so on the I'm trying to find it here on the EPA info page. I know it's there somewhere, but I'm going to show it to you in a different way here. So on the, we have a PDF that helps people to select. I think this might have touched on somebody else's question earlier. So this is, we have 3 tools at the moment, and as Queen's mentioned earlier, we might have more in the future. So basically, it's performance in practice, or PIP as it's known, consultation and procedure or physical exam, and then the case-based discussion. So really, the top 2 have to be done with direct observation, as Karina was saying there, the CNM, the registrar, the consultant. So they have to be, you have to be seen doing the thing. And I mean, it might only be a briefest of things, but you have to be seen physically doing that. Now, in your latter years, you might be doing things like recorded videos in terms of consultations, but there's a whole consideration around them in terms of data protection and consenting the patient. So just focusing on being seen in person. So the opposite of that is the case-based discussion, and that's you again with somebody who's appropriate to give feedback. And I can send this on in the group chat for you as well. The first question is to ask yourself: is the best aligned with the patient's age? If yes is the answer, you'll see the 18 EPAs there. It's very obvious which one to pick. You just go by the age group. If it's not, you go back to 13 to 18. So they're non-age related things of the patient. And then there's a trainer. So the trainer here can be exchanged for anybody who's appropriate to give feedback, observed you, and if the answer is yes, you use any of them. If it's no, you can only use the case-based discussion. And really, the third question is kind of almost superfluous, really. It's just you want to use the website or the app. For yourselves, I would suggest using the app, or at least having the app in your back pocket to pull out, because the website, I don't know what the availability of PCs is with the HSE, but generally it was pretty hard to log on to anything. And some of the meetings we've had with ED consultants and like have told us that everything's locked down at the moment. Nobody can access anything on an HSE PC. So,
all you need is phone coverage in order to use it, and also the app.
You don't need phone coverage.
You don't even need phone coverage. Yep.
No, just first sync. You can get all your tools onto it, and then it'll be saved on the app, and you can sync again. So if you're out of access in the middle part, it's fine.
There is one way.
Is there any particular procedures the GP has to do mandatory during this training rotation? Like I'm thinking of.
I was waiting for somebody to ask that.
You like marina coil and ring pastries. There are a few centers like Castlebar. They ask every trainee to do at least 12 or 15 independently before the finish of rotation. But here there is no nobody has given us any numbers.
Okay, so what we'll say about that is we haven't actually set out exactly what the requirements will be, because we want this to be a bottom-up development rather than a top-down. If you look at other programs and other training colleges, wherever they set minimum requirements and minimum numbers, these are always set arbitrarily. We're going to work with you iteratively over the next couple of years so that the requirements in terms of the review of these records are going to be doable for you and fair. And we are going to maintain the two big themes of simplicity and flexibility. However, what I would absolutely recommend you try and follow in your obs and gynae is things like obstetric antenatal examination and pelvic examination. And if you could get those, if you could get a few instances of those two examinations, and you do not need necessarily to get to the level of independent practice. We're not going to be chasing loads and loads and loads of conditions where you have to show you're at independent practice. This is what's going to be much more important, is that you show that you can learn, you can progress, you're a professional, you can develop communication skills, you can develop consultation skills. So this is not going to be a whole pile of conditions and clinical areas where you have to get to independent practice. We don't know yet exactly what the criteria will be, because we want some data to come through to see what's doable for you. And we always have the exams there as well as a backup. So this is more about those soft things that the exam doesn't measure. Things like communication skills, things like integrated clinical skills. But we are thinking at the moment that there will be some procedures.
I might come there.
Go ahead.
Yeah. So basically, as Karina said, that the issue with the minimum numbers is that it's superficial. So really, the way I would think about it in my own head, if I was in your own positions, would be that if I was looking after a patient, how many notes would I make in relation to that patient? It's variable. I mean, it depends. Some things are more stable, other things need to be reviewed, much more frequently. So as a general rule of thumb, I think that people will be using the tools, and I'm intentionally vague on this point, several times a week once it's fully rolled out. So once that's fully rolled out, it would be similar to that. You'll be kind of entering them regularly throughout the week. At the moment, because it only pertains to one element of your training, it might be less than that. But again, I would probably get going with it at the moment in your positions, because as Karina says, it's first in, best dressed. If you get your learning records made now and you come through this later on, you can really it adds a lot of validity to it. So I would front load your efforts and continue to do it frequently. Would that be fair to say, Karina, do you think?
Absolutely, but there's one very important point I'm going to make for anybody who actually hasn't put in a learning entry yet, and this comes up time and time again. When you open it and you've entered the case, let's say it's a 5-year-old with with asthma, for example, and then you go on to look at the six domains where you can record a level of supervision. Do not, please do not freak when you see there are 6 domains. You only need to choose 1, 2, or whatever you need that is pertinent to that case. We want you to have multiple quick entries. So when you get onto the page, which gives you a choice of domains from which to record your level of supervisions, with the PDFs which describe those domains, there are things like problem solving skills.
Well, show them, Karina, maybe easier,
yes,
right?
Show them, but you only need to pick 1 or maybe 2.
Give me a second here, so I might just jump around a bit.
And while you will find you'll probably need to look at the PDFs to get familiar with these core competencies at first, and you'll find that will be helpful from the point of view of you understanding what is expected of you. In time, the core competencies have been kept consistent throughout all the EPAs, so you'll get to know them fairly well in time. So I
don't have the fancy screen share for devices set up at the moment, but this is very similar on the device. It's just differently displayed. So when you go to, the only website you need to remember is ICGP/EPA, and then from there you can get links in terms of information. You can get the direct link login, or if you want to do it on desktop, and that's what I've done here. So this is the desktop login. So you log in. At the moment, you have to go to year 1. We'll probably be updating this to make it a bit more streamlined. You go to rotation 1. Ignore that cork thing. That's just a hangover thing. So we go down to just do case-based. Actually, no, I won't because I've done that a lot already. We'll do adolescent acute care, so case-based discussion. So this is just a preview here of doing it. So that's not actually the form itself. You go up to complete now. Again, it looks slightly different on the app, but it's the same content.
Would we do contraception since we're talking about obs and gynae? Would that be a good one? Or
I don't have much content. I don't have any content ready to put in, so I'm going to be putting X's in. So
yeah,
it's all it's similar for all of them.
Yep.
So basically, what you'll always start off with is it's only 3 pages, and I've said before, just think 3 minutes. If this is longer than 3 minutes, you're making it too much work for yourself. So the first page is a case description. So again, I'm just going, for the sake of today, I'm just going to copy this in and pop it in there. The dual level of detail is what Trainee was mentioning there. So this is the PDF described as EPA, but again, as Trainee was saying, you don't need to be reading this each time. Just maybe when you're starting off, you might want to click into it. And then once you're happy, you know what it is, you can kick on from there. So we put our description. I would say one thing, just make sure your description is enough that you remember the case. Obviously, you can't put in anything personally identifying with the patient, but there's not much point in saying like child with a cough. Do you know what I mean? Because when you come back to that in the latter years of training, you know, it's nice in your head if you can say, oh yeah, I remember that child I saw in ED who was such an age with such a, you know, presentation history. So just, it's good to put a little bit more detail in there, not huge amounts. These are the domains that are linked to the curriculum, and as Trainee said, you do not have to do all 6 for each event. You can be as little as 1. And again, there's a dual level of detail. Each domain has a PDF link with it. Sometimes it has nothing in it, and this one does. So again, these are just kickoff points to kind of clue yourself in mentally about where that domain is. We readily admit, and the people who came up with the domains do as well, that there's overlap between the domains. So don't stress about which one goes into which. Just ballpark it in terms of, okay, that's a comprehensive approach. I mean, so things like primary care management, community orientation might be more in your GP reg years, whereas things like specific problem solving skills will be more hospital based, and possibly holistic approach could be more hospital based. So we'll click onto that. Oh yeah, so that's what actually, Trainee, I just want to touch this again, you were mentioning. So at the start of your training, so, you know, you're training to be GPs, independently practitioners, independently practicing in the community. So, I mean, of course, we're expecting you to be at higher levels of supervision as you start off. And then as you progress through the years, you know, you could move up through it. You don't necessarily have to go through this linearly. And that's true of all knowledge. I mean, knowledge waxes and wanes, it has to be revisited. So you might be at moderate, let's say halfway through your hospital rotations, you might go up to independent practice early in 3rd year, you might drop back a bit closer in 4th year. And really that's fine, because these feedback events are just snippets. And I'll show you in a minute how they all come together. And they're just meant to feed together to give a richer picture.
It's important to say the level of supervision is for that case only in that time. It's not. So let's say we're talking about a 17-year-old presenting for the morning after pill, which would be a very complex consultation for you at your stage at this time. But the level of supervision is just for that case at that time, and it could of course have been a very complex case. So that's another reason why you might go up and down the supervision levels, but don't worry about that, just so long as the general trend is towards independent practice.
Yeah, exactly. So as we say, there's only 3 pages, so I'm going to move on to the 3rd now and wait for it to respond. So for those of you who've done other training schemes and other kind of higher levels training might understand or might see this familiarity. So there's areas of strength or excellence. And all these are kind of feedback, so it can be free text feedback or non-applicable. So you just pop in there, really a sentence, I'm not going to do it now, but a sentence or 2 here is max, because that's keeping you under 3 minutes. So if it's applicable there, then the areas for development, the action plan. So this could be varied. You might want to go to a specific resource. You might want to look for some more challenging cases. You might want to seek out some similar cases. You know, there's a whole variety of there. And that's that conversation that you're having between you and the person who's giving you your feedback. And then the timeline for yourself to have a look at that. So that's important, just to kind of flag and say, right, I'll have a little look and say, I'll get this done the next 2 weeks, because, you know, I find anyway, personally, without a deadline, nothing gets done. So you know, it's good to have little kind of reminders in the back of the head. And then the trainer signature. So trainer here is exchangeable with the person giving the feedback. And then if they want, they can put their email in here, but that's not required, and it might be removed in the next iteration of the tool. So I'm just going to put in some X's here to satisfy the tool's requirements for something to be in here. If you were doing it, I guess, yourself, and you were wanting to fill up one of these tools, I'd probably just copy in NA, because I'll show you later when it goes to collating all this together, X's might be confusing. So let's hit finish and complete, and that's it done. So I'll just ignore that screen. That's just something else that doesn't usually pop up. So that's it. That's it, kind of data collection or kind of your kind of feedback kind of event. Did anybody have any questions about that bit of it, maybe just before we go on to the other side of it?
I see Aisling is also perhaps able to speak to us as well. So Aisling, if you want also to make any comments, please feel free to.
Oh,
Sorry
Aisling,
about the technical difficulty.
I meant to come back to you earlier. Sorry, yeah.
That's okay. No, I just think it's a good idea that you can come back to this at any time during your training. So I know previously filling out logbooks, there'd be a lot of stuff kind of in those 4 months that you might not have seen necessarily depending on your rotation. And then you'd be going through it with your consultant and some of them might not apply, but you would have seen it perhaps on a different rotation. So I think kind of the being able to constantly put something into like an overall logbook is a good idea.
Yes, well, we will be moving away from this whole list of conditions that you have to go chasing towards what are you seeing day to day in actual fact, and how are you using that to push your learning forward. So it's a more holistic approach. It's a more learner-centered approach. It would be lovely if Brian is able to show you just how the data will display then, because I think there's a little bit of understanding about how to enter the data and you'll all get better at that as you practice it. But then the exciting bit is then what can you do with it? So Brian, do you want to?
Yeah, I'm going to jump onto that now. Just get ready. Now, so can you see that there? So this is very colorful and very busy. So what you're seeing basically is a kind of a mock-up of what we've been referring to as the dashboard. So this is kind of a way of, like, if you can imagine the data capture is the front of house, this is the back of house in terms of like how you run, you know, business or whatever practice. This is seeing what you're collecting, I guess, kind of holistically and overall in a very, very quick way. So we designed this so that, you know, you can imagine this person is this is a person who's doing, let's say, EPAs for doing feedback events for all of their EPAs, not just women's health. And what it gives you is it gives you a quick overview that you can have a look and see how you're getting on week to week, but also before kind of specific review time. So it's likely in future that this dashboard, and I should say to you that this dashboard that you see in front of you will be the same view that your trainers will see, is the same view that your scheme directing team will see. So you'll all have the same view on what's happening. So there'll be a shared understanding. And so you can use this week to week, but you can also use it before maybe kind of fixed review points. So that might be the case that, you know, you could have discussions, say, you know, you're tipping along in this and that's great. You could say, oh, maybe you could look for more exposure in this direction or that direction. And that's a conversation though that really should be happening the whole time and not just before the meeting, because, well, to be honest with you, it's before the meeting that might run into trouble. So let's just go through it a little bit in terms of what that you do. You can scan through dates. Let's say if you want to see what happened in the last 3 months or a specific time period, it changes the data below it and to the right. So I'll just show you what all that means. So this is in that year. So it's all color coded back to the forms. Those kind of tick boxes, or what are known as Likerts, there are your levels of competence. Now this is somebody in 4th year, but it's too linear. It's unrealistically linear because you can see that they're starting off at levels of close supervision and then they never touch on them again, which is not the case. I mean, the Americans call it hills and valleys, so they go up and down. So, you know, you can have little bits of higher supervision at the end, and you can have vice versa. I mean, if you're coming into GP training under the recognition of prior learning, you might have pediatrics done, you might have emergency medicine done. So a lot of this stuff up here could be happening earlier, but you have to remember you might have done a lot of that already, but you mightn't have done it to the level of a general practitioner. And the general practitioner's point of view will have a slightly different view on it, even if you were doing it to a high level previously hospital-based. Then we have it up here in terms of each EPA. And again, this changes color-coded for competence. And on the right, you can see the number completed. So we're going to go back over here. And we can see it changes there. So if you want to zoom it in a bit further, you can see it that way as well. This person might not be completing a huge amount, but it's only fake data, thankfully. So then you might be asking yourself, okay, well, if that's the tick boxes and the kind of Likerts from the tool, where do I see all the comments? And the way to do that is you go into detailed responses, go into, so you click on a part of it you want to see. So let's say the first EPA, which is acute care children, you want to see the areas where you've been flagged as, actually let's flip it around. Let's say the areas where you've got higher levels of supervision. If you go into responses, you can drill down, as they call it on the platform, into the free text there. So that allows you to see what's, and this is all just kind of junk data. But this allows you to see the free text here. And if you wanted to really kind of collate that free text with the Likert, or you can see it there. But I wouldn't worry too much about that. It's just about the free text there. And again, you might not find yourself doing this in depth very often, but you know, it might be nice to go back and see certain cases. Also, we'll have the ability to flag cases. So if you really want, if there's a certain case you really want to go back to, it'll be there, and that'll be something you can revisit. So might pause there in the interest of time and see if there's any questions on that bit.
Is that the first time that any of you have seen the dashboard or what the data could look like? Yeah, yeah, and it is going to give you quick access to lots and lots of data and really interesting history of how your learning has progressed. Can anybody think of any ways how that might be useful? Or is there anything that you would have liked to have seen on that dashboard that you haven't seen yet?
Or any concerns, any barriers you think to the use of it? We'll take warts and all comments, as they say.
Okay.
If I had to push you for one criticism of it, somebody must have something in the back of their head. They're just thinking, God, this is X or Y. Does anybody have any thoughts? Because see, things we've heard, not everything, but we've heard a lot of it already. So hopefully we might be able to address it. But if we're not, we need to hear about it. So does anybody any thoughts or anything around it? No. Fair enough. You probably, I guess, why we won't like these things is like you have to ride the bike before you can ask what riding a bike is like. Actually, we might actually have that platform live for you very shortly in the next few weeks. So for those of you, well, for yourselves, even the people who are not in Obscure, as we said earlier, if you want to start capturing data, you'll see it coming through at the other side. And we have to do a little bit of work in terms of translating it. But as soon as you start to capture it, within a few hours, or saying within 24 hours, it should be on that dashboard.
Can I ask for the trainer signature? So do you enter like an email address for the registrar or the kind of senior?
No, you don't need to. No, so the premise here is that that you would put in the name of the person who gave the feedback and maybe just their titles like PEDS, SBO, or whatever, you know, and then that would kind of feed into your learning record. And the person who's your clinical supervisor would still remain the consultant, but your consultant's feedback along with all the other points of feedback would be all together. Do you know that kind of way? So the consultant would say, oh yeah, I do recognize that reg, or I recognize that CNM, and that's grand, and do you know that kind of way? So it's about building up a picture. And I would suggest you try to vary the people you go to for feedback and also the tools used, because the case-based discussion is quite easy to use because you can sit down and do it over coffee. But like, you know, if you're in emergency medicine and the opportunity comes up to do joint examinations, or, you know, or something like that, it's very, very a specific learning thing that you could do in that area. Like, why not get that done then? And then when you come through to primary care, you know, you could end up delivering a service like that or something like that later on in your career. So you kind of have to make it work for you, I guess, is the best way to describe it.
Okay.
Any other points on that? Anybody bamboozled at the start of training and trying to figure out all the things they need to do? I see a few smiles coming back, so a little bit of bamboozlement, is there? It's okay. It's normal to be bamboozled. That's okay. That's part of it. It's part of the part of managing it all together. I guess if I was to give you one takeaway from the whole meeting, I'd say just drop me those emails, the guys who are having issues with it, and we'll support you to get you on the platform. Obviously, that needs to be sorted. But have this in your back pocket, and you know, for many ways, as long as you can just put it out after the word round and say to the registered consultant, actually, you know, we're doing this enactment test. Why are we doing it that time of the day, or something like that? Just something interesting you pick up on the word round. You know, that could be a point of entry and say, right, that's interesting, fair enough, I can go back to that. Because you'll be amazed, you'll be flying on all the things you're doing in given rotation during your training, but obviously you'll have to revisit it when you come out. So it's nice to have your own kind of genuine learning in the place that you can refer back to personally.
The other thing is, I suppose nobody has had the chance yet to actually show this app on their phone to their registrar or to their consultant and see what reaction they have. Now, we have contacted a few obstetricians around the country. We haven't managed to get everybody, but we have started talking to the director of the Institute of Obs and Gynae, Dr. Cleena Murphy. So she's very supportive of what we're doing here. If you meet resistance from a consultant in this, please let us know. It's impossible, obviously, to get around all the hospital teachers. But Brian and I also, if there's a hospital teacher who says, look, I want to know more about this. We are developing a video resource for the hospital teachers. So it'll be a 10-minute video for them if they want to look at it. And that should be ready in the next couple of weeks. But also, we're also very happy to try and meet with a hospital teacher if they say, I'd like to hear more about this, or I'd like to know more about this. Just let us know.
And the other thing to say is there's a lot of the other postgraduate bodies are bringing in very similar mechanisms. So whilst they might get a few odd looks initially, I know the NESIS have already brought it in. The non-training hospital doctors are bringing in a similar system. So it's not like the college, the ICGP is going off and doing something rogue here that nobody else is doing. This is the move. So when they look, and they might actually say, oh yeah, EPAs, I've heard of them from my medicine trainee or my so-and-so trainee. So, you know, don't feel that you have to bridge too much of a gap with them, hopefully anyway. Will we let them get a bit of lunch, Crean, do you think, or before they have to go back, or?
Certainly. Does anybody want to have a look at what the program, the scheme staff would see, the view that they would see? Is it worthwhile just showing that? I think yeah. So you will all have your scheme staff to help you along with these as well, and a member of the scheme staff who we think will be called the progress mentor will be each trainee will have their own scheme staff member who'll just be helping and keeping an eye on the learning records as they're recorded.
That's the person to go to if you think you're not getting enough exposure and say, right, well, I want to do this learning experience, but I'm not getting it, because, you know, it's like we have to facilitate this as well. Okay, so this again follows the dual. This is the only additional screen that you can't see. Don't worry, they're all Atticus is a fake person, so is Ali, so it's all fake. So the premise here is that the program directing staff will be able to see a cohort of probably just their own people they're looking after, or possibly the wider group. And again, it's got this dual level of use that maybe every once a week or once every fortnight they're popping in to make sure that you're able to continue to give to give feedback events, because I guess the logbooks could be gone, so there needs to be another mechanism in place. And then it gets very similar then if you want to get into specific people. So I'm just trying to see now how the
each one of those what looked like dials was a single trainee.
Oh yeah, so I should say that, yeah, because I'm so used to it.
Yeah, those are what are called spider graphs, and so there's 18 spokes on the wheel, and each of one of those spokes is an EPA. You also have that view for yourself, so you can see what your own spider graph looks like. It's just a different way of presenting the data, and it just gives you a lot of immediate information.
Yeah, so there's various ways of looking at this. Just waiting for the old data crunch here, but so you can see that that's the people completing it there, and let's say for example, Kale is for some reason quite underexposed or something's going on there. So that's the whole advantage of this, is that it's not just, I guess, digitalization for the sake of digitalization. It's really kind of bringing the usefulness of this content out for yourselves, for your program directing teams, etc. So Kale there might be something going on. That might be kind of leave, or it could be maybe there's just the rotations aren't great or something that's going on. So instead of finding out in the last week that, oh, I never got a chance to do X or Y or Z, it's a much earlier conversation. You can see the rest of them there are kind of whatever, 120, 100, 106. So it's kind of it's around that group, around that kind of area. The rest of the views and that's are the same as what we saw earlier. So So the whole idea is what you see on the drill down is the same as what your program director is seeing, but obviously you just can't see what your peers are doing. That's appropriate. Okie dokie. Any questions about any of that, or?
What did you think of that last view?
We should say the views were designed in a focus group that involved all parts of training, including trainees in the earlier part of this year. So your colleagues ahead of you, a few of them were involved in that. So that's where we kind of got our influence in that.
And also there's trainee involvement in everything. So the other thing that is the next step is the working group to set up the processes for the review of the learning records. And we're looking for trainee representatives on that, because your input is really important to make sure it can be as fair as possible, as doable as possible, and is centered around supporting your learning, but making you into safe doctors at the same time.
Yeah, so I guess probably the best way to do that is to get in contact with our local reps, because we as the college will go to the trainee organisation, and then the trainee organisation will put forward people to be part of that process. So, there's no reason why the first years can't be part of it, for sure. So, do you know your reps in the scheme? Gentle nods. I just think there's a unanimous. Well, you should be able to figure it out pretty quickly. If not, maybe somebody might have left who's in fourth year. You need to. Maybe that could be you then taking over from them. But yeah, so we'll go to the trainee organisation and then they'll put the name before the names. It might actually be great actually if some of yourselves were part of that trainee, I just think, because
it would be wonderful, yeah.
Yeah, you're a core cohort, and you're yeah, we brilliant if you could. Yeah. Okie dokie. We call it screen, I think, or we have.
I'm just going to give it a last 20 seconds. Does anybody have any slight discomfort about any of this? Please tell us if you have.
No, I think it's a very good initiative. Just one thought and one question. Is there any minimum or maximum number of entries we should be aiming at to put in this EPA,
Very good question, Brian. Go ahead, Brian.
Several per week is what I would say to you. So that's intentionally vague, because the problem with minimum numbers is that it's how can I say that your minimum is the same as somebody else's minimum? So if you say, like, if somebody came through and they, for example, let's say they were doing PEDS as their first rotation and they trained up to be PEDS consultants previously, now they're back as PEDS SHO. I mean, is that fair to compare that person with somebody who's, let's say, has come through from internship? It's an interesting question. I guess, as Karina said, it has to be assigned, but I would get into the habit of using several a week. So I would literally try and do it several times over every week. And, if it happens to be that only women's health log is covered by at the moment, and you're only seeing that, maybe that'll be a bit less at the moment. But I mean, you'd be amazed how much women's health comes through ED, how comes through general inpatient care, especially outside of Dublin, where there's more kind of cross-cover in hospitals.
And the other important thing is a learning entry that you collect now for women's health. That exact same learning entry would also be very useful to show that you really are learning well in adult chronic conditions, in adult acute conditions, in patient advocacy. So I think that the amount of learning records that would show that you've become proficient in women's health is about 25 to 30% of the entire number of learning records that you would need to show that you've become a proficient GP. So again, the flexibility of this is that any learning record could have multiple functions. So every single one of those is a boon.
And it's not, as we were saying earlier, it's not like, Pokemon or whatever. You have to get to independent practice in all of them as fast as you can. That's not the point either, because obviously that's not expected of people at start of training, middle of training, maybe towards the end, possibly. But don't feel that if you're being flagged for higher levels of supervision, that's a big taboo, because it's absolutely not. It's what's appropriate at your stage of training. So that's fine.
Great.
Okie dokie.
Good. Thank you all for joining us. You've made some very, very good points. You've asked some very good questions. We are very sorry about those of you who have seen the blank screen, and we will resolve that as quickly as possible. If you hear that that is happening elsewhere, please let us know. We are here to try and make this work for you. So if you hear of problems, please encourage everybody to drop us a line to curriculum at icgp.ie, because we believe in this system. We think you're going to like it, and we will do our best to support that.